Bad news is usually seen as any adverse or serious effect on individual about his or her future. That is what Bockham 1984 said about bad news. But there have been a lot of definitions of bad news, especially coming from the oncology section, because that was where some of these bad news issues came up. And according to Bear et al., the group of oncologists in 2000, they said a bad news is information that has an adverse and serious effect on an individual's view of his future, noting that bad news is always a subjective appraisal by the individual receiving the news. That is their own perspectives. So a news that is going to affect you adversely, either now or in the future. And you can see where it's coming from, because they deal with cancers, and we know there is cancer implication. Now, going forward, you can see that bad news, if you go to dictionary definitions, anything that can affect you or has some negative consequences and all those things, those are what we consider as bad news. But for the purpose of this discourse, we are looking at bad news from the health professional perspective, and we'll tell the view of the oncologist. Okay, so we are seeing it as anything that is going to have adverse effects in what we're doing, either now or in future. And that is about the way we feel generally. It's not always very easy to tell someone that he has this kind of illness that is terminal, or the person is going to die. If we can use ourselves as an example, when we fail exam, that is a very simple one. And people have to tell us that we have failed an exam. What will our reaction be? If the person goes straight, Omo, you don't fail. Oh. You see, sometimes we take it with a pinch of salt. That means we're going to deny, okay, that must be another person's result, not my own. That's usually what happens. So conveying bad news is something that is done in a skilled way. And we look at it as a form of skilled communication. And it's not always very easy, because you have to take into consideration the amount of the truth you are going to disclose. And some of these things are very subjective. As a result, we always prefer a properly structured and well-orchestrated communication that is going to have a positive therapeutic effect. The reason for this is not far-fetched. How you disclose a bad news to a patient, how the patient receives this bad news would go a long way in making that person adhere to whatever treatment concerns you have, or an outlook, the person's outlook to the problem or the situation. Now, the aim for any health professional is to use these skills to deliver bad news clearly, honestly, and sensitively, in order the patient can understand both and feel supported. Now, remember, this bad news is going to have negative consequences. And if you say it in such a way that the person would think that, oh, the end has come, okay, it's going to affect the outcome. Now, there are so many ways we can break bad news to patients. And there are different frameworks. The framework we're going to be using today is the one by Bale and Bachman 2000, the oncology approach. And it's usually called the spikes approach. There's another approach that was gotten from the spikes. It's called the break approach. And there have been other approaches too. But the spike approach has been very common and have been found to be very useful. Okay, so we are going to look at, because we have to take this consideration the time, and probably if we have enough time, we'll do a kind of role play to see how best we can do this. In general, the more attention is given to each of the points, the better the performance is likely to be. And these points are what is contained under the spikes approach. And it's also very important to plan as carefully as possible and to respect the people whom the information is being given by listening and watching them at all stages. That is where you have the opportunity of seeing them face to face. And that brings into view the courageous client-centered approach, okay, where you have to empathize, where you have to congruent, where you have to listen actively, and where you are going to be non-judgmental. These are components you bring in into breaking bad news. Now, look at what the spikes approach says. It says six-step approach or protocol for delivering bad news. Now that we understand what this bad news is, and let's bring it back to our own situation. Now, our patients have been diagnosed with COVID-19. And we know what COVID-19 is and how people see it. When it first started, there was a lot of death instinct around it. So that when anybody is diagnosed of COVID-19, the first thing that comes to mind, am I going to die? In fact, it's even still happening to our patients up to now, especially when they get into the isolation center. A lot of bad memories come back to them. Can I come out of this place alive? So these are some of the issues surrounding the situation. And we know that there are a lot of myths around this COVID-19. That means by every aspect, people already seen it as a potential threat to life. And that's something that is going to change their future negatively or otherwise. As a result, we have classified it, telling someone you are COVID-19 positive as a bad news. So how do we tell people that they are COVID-19 positive? Being that now from all angles, it can be classified as a bad news. First, you have to set up the interview. You don't just call somebody, you wouldn't know where the person is and say, oh, we are positive with COVID-19. Maybe the person is in a bus. Maybe the person is where he doesn't want people to know what is going wrong. And now you tell him that the reaction and all those things is going to go a long way in telling you what the outcome of such news will be. Then the next step is assessing the patient's perception. Now, from where did we get the spike approach? Now look at step one. The catchword there is the S. Step two, the catchword or the functional word is perception. S, P. Now the step three is obtaining the patient's invitation. That is the I. Step four is giving knowledge and information to the patient. That is the K. Then step five is addressing the patient's emotions with empathic responses. That is E. Remember I talked about the courageous ingredients, okay? And when we talked about empathy, you can see where they are coming out. So along the line, you'll be able to know what giving empathy is. Then the step six is the strategy, okay? Now, breaking bad news in this COVID situation and the circumstances we find ourselves might not necessarily follow this sequence, okay? But we are going to go through all the sequences, then we abridge it during role play, taking into consideration the work we do with COVID patients. So let us see what these steps involve. Now, setting up the interview. Here, the aim is to get the physical context right, maximize the privacy, and avoid interruption in order to help the patient to listen and understand what you're saying, and in order to respect confidentiality and provide support when needed. And that was where I was saying, assuming you are in a bus, I don't think you can be able to do this. Okay? Now, look at the focus of the key points under this step one. What? Under what you say, make sure you have checked all the available information. and have the test results. For example, you are going to tell somebody he's positive, you're not going to mince word about that because you have cross-checked and you are sure that, oh, this person's result is what? Positive. Then you decide the general terminology to be used. Now, the next question is where. That means you are going to arrange for some privacy. Now, what do I mean by arranging for some privacy? You are going
Hello, Dr. Umeh.
Oh, sorry. I have been talking to myself all this while. Hello? Hello, can you hear me now?
We are back, yes.
Okay, please, where did I stop? Because I've been ranting and ranting away since. Where was the last place I stopped? So that I can
Maybe you should just setting up of the interview. Just pick up on this slide.
Okay, I'll go back to the setting up of the interview.
Okay, can we just ask people to mute their mics? We still have quite a few mics on. Please help us mute your mics, please, as you come into the session. Dr. Shasheun, please. Dr. Lebimoyo, please kindly mute your mics. Thank you. All right, Dr.
Okay, like I said, the first step is setting up the interview. And the aim of this is to get the physical context right, maximize privacy, avoid interruption, and this is to help the patient listen and understand, and also to respect confidentiality and provide support. And how do we go about doing this? Some mics are still on. Now, I talked about what? Under what, make sure that you have checked all the available information you are going to disclose. And there are, you are going to tell somebody that you are COVID-19 positive and you know the emotional consequences of telling person such. What if that person is not negative? So that's why it's important we cross-check the result we disclose to people. Now, you decide on the general terminology to be used so that the person will not misunderstand what you are saying. Then the next one is where. You are going to arrange for some privacy. Like I said earlier, you have to ask the person, where are you? Where you are now, is there where you want to discuss? You want to talk privately? Are you with some people you can trust? You need to know where and how conducive the place is. Now, who? Are you going to talk to the person alone? Or are you going to ask if the person will not mind other relations or trusted person being around? Okay, these are some of the things you need to consider before you start off. Now, in starting off, you are going to do introduction and appropriate opening. What does that mean? Okay, I am so-so and so from so-so and so. Like we are, oh, my name is so-so and so. I'm a team member of this COVID-19 psychosocial team. And this and that and that and that. Okay, I hope I can go on talking with you. You wouldn't mind. You ask for that permission before you are letting. When that is done, then you know you are ready for step 2. In step 2, you are going to assess the patient's perception. Here, if it were to be a cancer patient, we'll take into consideration certain things. But here, we're not going to be seeing the person. We're going to be doing communicating via phone. Then all you need to do is try to find out how much the person knows. And in this case, the person must have done the test before you break the news. That means he must have known that COVID is this, COVID is that, for him to go and take the do the test. All right. So to some of us, you might start by saying, I learned you did so and so test days back. What do you understand by that, and what does that mean to you? So that usually we ask an open-ended question where you're trying to draw them back. You don't ask a yes or no question, so that from their talking, you'll be able to know how far they understand the condition, and probably what they must have been told about the condition. Okay? And you'll be able to know whether the patient is in denial. Some of them might tell, okay, I did the test, but I just did it for the sake of doing it. I don't even believe, and other things. You'll be able to know whether they are in denial. Then the next one is obtaining the patient's invitation. After you have gotten all this information about the patient, knowledge of the problem, you want to know how much the patient wants to know about the condition. You are not going to impose what you know on the patient. Okay? It's not like you want to ask them, do you want to know? No, but at what level the person knows, so that you'll be able to know what to add and what not to add. For example, you might say, would you like to tell me, or would you want to tell me the details of this condition? If this condition turns out to be good or bad, okay? Are you the kind of person who exactly want to go on with more information about this condition? Okay? Then some people might say, I don't want to know anything about this. To me, it's all rules. It doesn't make meaning to me. So then that ends the discourse, because you don't have to go beyond what the person is willing to know. Okay? So we'll look at step 4, giving knowledge and information. When they have given you the signal, okay, I want to know more, okay, I want to know this, then first decide on the objective for this consultation. What is the objective of this consultation? Breaking the news. You want to let the person know that the result of the test he did some time ago is out, and that person is what? Positive. Now, are you going to start downloading everything you know about COVID-19 to this person? No. So stick to your objective for this consultation. And by implication, this does not mean that you forge blindly ahead with your own agenda, ignoring the patient's responses. As you are saying, you are collaborating or trying to understand whether the patient is going with you. Now, here, usually the 4 crucial headings are diagnosis, treatment plan, prognosis, and support. But due to the nature of the job we do now, you might not be able to download all these things to the patient, okay, because you're on phone and you have limited time to pass the information. But if by adventure they want to know, okay, I'm positive, that is the diagnosis with COVID. They want to know what are the treatment plans, okay? Then the information available to you is, we just have to let you understand the nature of this problem so that we prepare you for the evacuation team to come and take you to the isolation center. Some of them will want to know prognosis and support. It's not within you to decide the prognosis, because you are not, that is for the case management team. Your information is to let them know that, you have a management team, you have an evacuation team, and this and that. And at any point, the team that it falls on their lap will act accordingly. So then you move on to step 5, addressing the patient's emotion with empathic responses. Now, sometimes when we try to define empathy, we're looking at how we can be able to connect with the feelings of the other person. It is not the same thing as sympathizing with the person, because some of these things have their own impact on you, disclosing the negative information. You try to be in the person's shoes, knowing that, but don't try telling them that, I know how you feel. You don't know because you've never been diagnosed of COVID-19. Okay? Rather, you can parry as, okay, I know that when someone comes down with COVID-19, there are a lot of emotions that come with it due to the fact that information is still not very clear on the cause of this condition. All right, but you can be able to say, all right, you know also that a lot of people who have been treated and they have what? Recovered, and they can give information about recovery rate. Okay, yes, and you can see you are not saying you are in his shoes, but you are collaborating how it goes. Okay, now remember, this aspect is always very difficult because a lot of us don't even know how we feel about certain things. We can't interpret our emotions. Now look at us now trying to be in another person's emotional space. It can be a bit difficult at times. And that's why it requires a bit of what? Practice and training, so that, or if you have been doing it over time, you could see that you can easily flow. Now, when such a bad news is broken, some patients' responses can vary. Some might go into distress. Some might go into denial. Some might get very angry and aggressive. Okay? These responses vary. But there's one important thing. You that is breaking the bad news, it doesn't matter the response from the other side, you should not allow your own neurotic tendencies interfere with the feeling of the client. A lot of us are very emotionally unstable. Probably when they go berserk, get out of my phone, this and that, then you react that way. No, that means you haven't gotten the training. Your training is to be calm and listen to the distress level of the opposite side, either the anger or the denial. And when you are calm, you'll be able to know how to broach the issue. And there's a lot of emotional intelligence applied to this. And that is some of the things we would handle ourselves. Okay? In doing this work, you are not in focus here. Okay? You must put your emotions into check. Now, you observe the patient and give them time if some of them suddenly go silent. What you need to do is, are you still there? Okay, I know that this news could not be good to you. Nevertheless, there are solutions, and a lot of people have gone through it. So while the patient is trying to recover to start interacting you, you are using this prod to get the person to converse with you. Now, you also have to acknowledge any shock and ask them what they are thinking or feeling to keep the conversation going, because as at that time, your ability to engage the client will go a long way in making the client listen and carry out your instruction. Now, you have to also listen and explore if you are unclear what the patient is expressing, and then respond empathically. Then, empathy allows the patient to express their feelings and worries, and then you provide the necessary support. You must not argue with the client, okay? No matter what they say to you, you do not argue. Now, allow expression of emotions without criticism. If he's angry, allow the person to be angry, allow the person to express the anger, then you come in, because there's always a lacuna when they react that way. So it's your job to know when to catch him and to be able to deliver the critical information. Then step 6, strategy and summary. Here, we demonstrate an understanding of the patient problem list. Some patients are more knowledgeable than others when it comes to some of these issues. Okay, by where you have been interacting with them, you have been able to place that patient at certain level. Okay, and some might go further to ask some questions about going forward. What is expected of them? Okay, what am I going to do? Now, these are some of the things you will have articulated beforehand in case there is need for them. And you are going to demonstrate an understanding of the patient's problem list. Some of them, they have concern, all right? Some will tell, okay, if I'm going into isolation, am I expected to go with anything? Is there any strategy or any plan? Now, preparing for the worst and hoping for the best. And what does that tell us? Like the lecture we had with Rakasi, you must be aware of what goes on in the treatment. We are not saying you are the expert. You have a perspective on each of the what each of the pillars do, so that you can provide oversight info. And meanwhile, you are telling the person that, okay, this will be taken care of by these people, but this is what they do. This one will be taken care of by these people, and this is what they do. It shows that you are in control of the situation. Unlike when you are asked a question, you don't have any answer. Remember, the trust you establish goes a long way in making this disclosure a success or a failure. It might also help you in identifying some sources of support for the patient and incorporate them. You can also invite questions. If there are any area the person don't understand, or like sometimes we do have, so might ask you, oh, now that I'm a positive and you want to take me to isolation, I'm living alone and I have 2 kids I'm taking care of. What happens to these kids? Okay, so you'll be aware of going on within the team, so they can be able to, if you don't have answer to that, you simply tell them, okay, I have noted what you said. I'm going to escalate it to so and so persons who will be able to provide the necessary answers. Then tell them what happens next if there is need, okay? And in that case, what happens next in this our case is, after breaking the news, you prepare their mind for evacuation. But you know, we're having problem with evacuation. Some of them will ask you, are they coming to take me now? When are they going to take me? And some of them might require specific time, an hour. And like we all know, this is not within our what? Territory. You can't give them time. You can't defend. Okay? Then you provide the necessary answer. That now you have prepared the person just to get you ready for evacuation. Now the evacuation team will contact you, and you can agree on the time with them, because it's not for you to tell them when they are coming to be evacuated. Now, when you are done with that patient, you know, sometimes we have about 10 or 20 patients we need to reach out. Based on the way the interaction has gone, you need to check your own feelings. Remember, some of us have the tendency of carrying other people's emotions. Maybe when they are crying, you also cry. Because when you tell them, oh, you are positive, some break down and start weeping. Oh, my life is finished. This and that and that and that. In the process, you see yourself being caught up in that emotional web. Okay? And remember, you still have other patients to break the news to. By the time you are done with that person, you're exhausted emotionally. And you are feeling so bad. And by the time you pick the phone to call the next person, you are just a wreck. This is not expected. And that's why we say you check your emotion after finishing one conversation and ask yourself where I am emotion-wise. Can I go on with this? If you can't go on, you quickly call another person, not one of the patient, a friend, to desensitize. How do you do that? You can tell the person, oh, I just spoke with somebody who is emotionally down. Okay, I needed to get myself up again and just chat over do things and this and that. Engaging in such chats, you start feeling better again. Afterwards, you can now call on the next person. Now, you have to deal with the next patient sensitively, as they may have been neglected. Probably over time, nobody has reached them. Here, because your emotion is now very epileptic, you now, due to the outcome of the last one, you zoom into this other person without being sensitive to what the person might be. And the person might be rude and say, Don't call me. Don't do that. I've been waiting for you. I've been doing that. I've been doing that. Or some other person have called me. Why are you people bothering me with this kind of bad news? You could see you have to gauge out those things and be able to know how to come in. Now, studies have found that the manner in which this bad news is conveyed can have a profound effect on both the recipient and the giver. It can have, if it is conveyed the appropriate way, you could see that the patient will understand the situation better, will internalize whatever information you have passed across, and will be open to more discussions, as well as the treatment adherence to the treatment. Such cases tend to give good treatment outcome. But if it didn't go well, there's going to be what? Doubt and mistrust. Okay? And that's why some of them will say, that's why I cannot trust you people. This one will say A, this one will say B. Okay? And once you lose the trust of your patient, you will find it difficult winning it back again. Okay? So some of these things are why we have to be at our best when we are delivering bad news, because it goes a long way in enhancing compliance and treatment outcome. Now, this is just a little brief about this. So probably when you ask questions, there will also be room for role play. Let us see how we can articulate what we have said here, okay, in about a minute or thereabout, or even in 30 seconds, okay, taking the steps that are peculiar to what we do as a kind of role play as time goes on. All right. So thank you for listening. I can entertain questions.
Dr. Shodi, are you there?
Please go on, Dr. Jokumbi. You can answer the question.
Okay.
I'm here. Please go on.
Oh, okay. Because
Dr. Jokumbi, you can answer.
All
yes,
right. Thank you very much, sir.
Thank you.
For the very enlightening section. If you are in psychosocial group, this is very key, if not the most important aspect of the work. So we are very grateful, sir.
Thank you very much.
So do we have any question? Please signify by raising up your hand if you have any question. Okay, if you have any question, unmute yourself and ask your question. Does anybody have any question for him? It's either we do not understand or we understand everything. Hello?
Yeah, good evening.
All right, good evening.
Maybe can I make a suggestion?
Yeah.
Okay.
Someone
talking?
Yes, somebody wants to ask a question.
Okay, please ask your question. I was going to make a suggestion also. Please let the person.
All right.
Point, why breaking bad news, you said we should find out from the person how much the person wants to know. And if the person says he is not interested in getting the information the caller wants to pass across, he has to stop there. Now, we assume that every person we call is positive. Are we saying that we wrap up the conversation and not tell the person, or do we find out if there's any other person in the house that we can talk to, or do we just wrap it up there? The person is not interested in what you want to say. Do you just seal it up and end the call, or what do you do after that?
Okay, I think there's a skip there. You have broken the news, all right, before you want to obtain more information. Now, that one comes in, when you have broken the news, you want the person to know more about the situation. And the person, when you read the news, some of them will go hysterical at this. Then in the process, you need to educate the person more. And then you call to know whether the person wants to know more. If some of them don't want to know anything about the condition further, you call a stop there. All right? It's not before you break the bad news.
Okay.
I think that is where the mix-up is.
Thank you.
Yes.
Thank you. Okay, thank you for that response. Is there any other person in the house? Please unmute yourself if you want to
Yes,
ask.
ma'am.
All right, please go on. Go on, please.
Yes, thank you for the lecture. Please, I want to know if, from what you just responded to now, are you saying that if the person needed to be isolated, we are not going to give the information to the person that, okay, for the next thing is for you to get evacuated and so. Are you saying we
No.
just telling, okay, since the person is not interested in getting further information?
If you go back to the slides where that was mentioned, okay, it is adding more information to the condition. Now, what is the condition we're talking about? COVID-19, is it not? Now, you have told the person earlier that, okay, you are COVID-19 positive, all right? And COVID-19 is this, COVID-19 is that. Do you want, based on what you already know, do you want more information about this, about that? All right?
Okay.
That excludes the procedural issues. What you are mentioning now is what? Procedural, which you must deliver. You understand?
Okay.
So where the problem lies is additional information about the condition.
Okay.
That is where the issue is.
So if in that sense, doesn't mean that the patient has to be forced
The person has to be done what?
First on getting such information. If it's possible, for example, if the patient is
No, it's not
hands-on,
information about the treatment and other things.
yes.
Okay. Now, for example, yes.
Deny being treated. They are saying they don't want to get treated and other thing that it's just malaria they are treating. They should leave them.
Okay. If the patient is like, you don't want to know about this condition, remember they are positive to COVID-19, and your job is to prepare them for what? Evacuation. And in preparing them for evacuation, they might not want to know any other thing about COVID. Rather, they might want to tell you that they are suffering from what? Malaria. Okay?
Yes.
But your information says that they are positive for what? COVID. Then you're no more going further to educate them on what? COVID. Rather, you're going to inform them properly about the COVID protocols. You understand that?
Okay.
Okay, because you are positive, then somebody will call you for evacuation because you are going into what? Isolation. Then the other is before you are taken for isolation, you are expected to maintain all the what? Safety measures. Can you see the way it's going now? So those are the protocols you must deliver. The other one the person rejected is maybe like you could see the kind of lecture we had yesterday from Dr. Kasi on the biology of COVID. All right? Some will ask you information about that. Some want to know. Some might not want to. They say, already I'm positive. Anything about COVID, I don't want to know. Do whatever you want to do so that I'll be treated. That is where that one stops. But not in delivering the what? Protocol.
Okay. Thank you.
You're welcome.
Okay, thank you, sir. Yeah. Is there any other question? We would like to finish today by 10 o'clock. Any other person? Okay, if you have any question, please unmute yourself and ask your question. I'm not seeing any hand, and I don't know whether anybody is asking.
There's a question in the chat box.
Okay.
Yes, and I'm sorry, I was going to say, Dr. Shokunbi and Dr. Umeh, that Dr. Umeh, and I know Dr. Fashanu is here also.
Okay.
In the course of these disclosure calls, there may have been one or two tricky examples. Like I remember, so maybe you may want to cite just a few. I know you can't go through all of them, just what the common experience has been, particularly for those that have been doing it. And maybe we could take one or two of those.
Okay, they are here already. Okay, maybe I will get two persons to role play it. So
I
that
think
we'll make input.
it will be to make,
So let somebody volunteer to be the patient, and another person volunteer to be the what? Person that is going to break the news, and let the person follow the procedures we have just enumerated to break the news. So we need two people to volunteer to do that quickly. It's not going to take you to.
Can I just read the questions first, sir?
Okay, all right, go.
Before you do that, okay. Thanks for the information, sir. In case of a client with domestic challenges, for example, a single mother with 2 kids and tested positive to COVID-19, how can such person be prepared?
Good. It's very simple. You have introduced yourself, this thing, and you have asked where the person is and those things, and you've broken the bad news. So this one is coming after the bad news has been broken, as okay, issues around that. Okay, because you said that the person is going to be evacuated. Then you said you have 2 kids that should be handled, and where are they going to stay? No relation, that. Remember, you don't have that answer to that question immediately. Now, you can tell the person you are going to escalate to other senior colleagues or other teams for an answer that you call back to me. So probably when you escalate such cases, you remember we've had such a similar case like that, which Dr. Oshediwa tried to handle, and which we try to get a place. In fact, the social workers were involved there now to know whether there will be a home for such kids. But we never actually made success out of that. Okay? So invariably, what will be available is you explore whether that person has siblings where the kids can stay. And if adventure the kids were tested and they are also positive, yes, we have such cases where the kids and the parents were admitted. Okay, but you can't have answers to this without what? Consulting immediately, because there's no protocol now that provides for that. That is the clear situation on ground about that. Probably because Dr. Oshede has handled such a case before, she can also add to this.
Yes, thank you, Dr. Mel. I was going to actually say that we've also had situations where parents come along with their children to the isolation units. We've had a situation where a mom was positive and baby was negative. And we've also had where baby was positive and mom was negative. We've had situations where mom was negative and the children were positive and they were admitted together because really they just realized that we didn't have any option. No one was going to take the child and they had to go in with the child. Unfortunately, they were tested, they went through the treatment together and got discharged. The case that Dr. Umeh refers to was one of, I think, our very first challenges we had around this. I think it was husband that was first diagnosed. Then later wife received a positive diagnosis. They were both on admission. Grandma was at home with the children. Then grandma received her positive diagnosis, and then it became a huge crisis, what was going to be done. And we recommended that the children should be, housed in one of the social welfare settings, and the social worker was on standby literally to make that happen. But the state response for some reason just didn't process that. I think eventually they had a relation who took over those children for a period of time. Don't forget that once they hear that your mom and your dad, they are positive, nobody wants to take those children. So it really usually presents a very tricky and complicated thing. So like Dr. Umeh said, it's important that you don't think you need to sit with it and solve the problem. You don't need to sit on that. Just escalate it, and we can only try our best. If we can do something by our, alerting people that are involved, fine. And if we can't, we'll just know that we've given it our best shot. So there are varied ways those kind of scenarios can play out. But I think there's always a way around it, and we've seen different ones. Thank you.
All right, thank you. Well, there are 2 questions, but I believe that at the end of the section, we would have answered the question. So maybe, Dr. Umeh, you can go on with the next.
Okay, just a question of, let us role play. 2 persons, okay, let's say the new persons, 2 persons will be ready. One should be a therapist, one should be, the patient, and one should be the person breaking the news. But let's, from the older persons who have been doing it, let's role play. This is what they have been doing. So we're going to have 2 sets of role play, one from the older ones and one from the newer ones, so that we'll look at what happens within, how some of these things are integrated in breaking the news. Okay? So
can I suggest that the 2 role play should be from the older one? Because they know, yes, I think it's better.
Okay, let's just do one then. Because just to give them the opportunity to look at what it looks like, trying to break down news within a few minutes. Okay.
Okay, sir, no problem then. It's okay. Yeah, if it doesn't work, then we'll now.
All right.
Yeah.
So let's see the older ones. Do we have 2 persons that will volunteer? Volunteer, let's start. This is what you people have been doing.
Hello.
Do we have anybody here? From
we need volunteers though, so that we can leave this place quickly. Yeah. Please volunteer.
Well, maybe most people here.
I would like to volunteer, but I'm just joining the meeting. So I don't know if anything has been added to what we've been doing before.
Okay, that's fine. I think it's fine. You've disclosed before now, haven't you?
Yes, ma'am.
Have you disclosed results before? You have.
I've been disclosing. I'm saying I'm just joining tonight's meeting. So I don't know if there have been any additional.
Okay, you're up. Okay. So who is going to answer this?
Please. Oh yeah, good people.
David, you are here and you are keeping quiet. You want me to start calling you? Huh?
You want to start harassing people, Dr. Umeh?
No, let me harass them. They're all keeping quiet.
And they're expert disclosure people. No.
You imagine?
Please just call them. Let them.
Okay, David, take over.
Okay, Immaculate. Someone has put up their hand. Immaculate has put up hand.
Start immediately. Before it's short.
Oh yeah.
Somebody's mic is disturbing us. So. Okay, David, are you the disclosure? Or Immaculate, who you take the roles and do this thing? We don't have all the time to.
I will be. Okay. I will be the person disclosing. Okay.
Okay, call and start immediately.
All right. Hello, good afternoon.
Good afternoon.
Okay, am I speaking with Mr. David?
Who's speaking?
Okay, I'm Yetunde Akiniro. I'm calling from the COVID-19 psychosocial response team. Please, are you Mr. David?
Yes, how can I help you?
All right. How are you doing today?
I'm fine.
Okay, so I understand you did the COVID-19 test.
Which of the tests? Since when?
How many have you done?
You should tell me now. You're not part of the team. You should tell me. You should tell me.
I have with me a result here, so I don't really know which of the tests. That's why I'm asking you. How many have you done?
Did you not say you are from COVID-19?
Yes, I am from COVID-19 psychosocial support team.
Are you not NCDC people? You guys collected my sample now for over 2 weeks ago. Over 2 weeks ago, you did not say anything. So you're not asking me when did I do test? Are you not supposed to have the information?
I know. I'm sorry about that. Please, I hope it's a good time to talk.
Yeah, you can talk now. At least I pick your call, so you can talk.
All right. So I have with me the result of your test.
Okay.
But before we go ahead, can you tell me what you know about COVID-19? I mean, what you understand by
Don't worry,
COVID-19?
I know everything. We just see them for social media. I know everything.
What do you see on social media? Hello?
Your patient has got the phone.
My patient has run away.
My result. What is my result?
Patient, this David, what David has done for us, he has literally depicted what this patient is.
Honestly. Oh,
Honestly, that is
fantastic.
how those calls go.
Fantastic
They are
patient.
irritated, they are impatient, they are rude, because they're just wondering that, well, what do you want to tell me?
tell you.
David, you deserve a award, though, even though your network has
In fact,
That's what they do to us.
it was too much. Wow, that's good. But please let them conclude.
What Madam Yetunde is doing, she's going in the right direction, because eventually you will still be able to break the news to them, one way or the other. But they probably may not give you, from my own experience, a lot of people are receptive, and we still have a good number of people that are not receptive at all. So that's just.
Please, don't just assume. Continue. I want you to finish.
Yeah.
Okay.
Because of the new people, yeah.
All right. So, Mr. David.
I'm with you.
Okay, you are here to tell me what you think about COVID-19.
Well, the people said it's a virus, and me, I don't have any. I'm fine. I don't have any infection. I'm eating well. I'm playing. I'm going everywhere. So, I'm not schooling. I can do everything well. So,
okay. So would you like me to enlighten you about the virus, just to tell you more, to add to what you already know?
No problem. Well, tell me.
All
In
right.
case
Okay, COVID-19 is a respiratory tract infection, and it causes symptoms ranging from mild to severe. And there are some patients that don't feel any symptom at all. We refer to them as asymptomatic patients. That is, you don't have any symptom. You can go about your daily business. You won't even have the slightest of headache, but you are still a carrier of the virus. And such an individual can pass the virus to other people. So do you understand what I've just explained now?
Yes, I've heard you. At least I heard that one.
All right, sir. So would you like me to go ahead with the result of your test?
Tell me now. You tell me. At least you have the result. Just tell me the results.
Okay. So the result of your test came out positive.
God forbid.
Okay. Why do you say that?
I told you I'm fine already. At least if you want to come and see me, I will give you my house address. You will see me. as I just even finished eating a bowl of amala now. So I'm fine.
That's good. You said you are fine already. Was there a time you were not fine?
I am always strong, ever strong.
Okay. So why did you do the test?
They said I should come and do now. They came to our house and they said that we had contact with somebody that was positive, and they collected our sample. So that's it.
Okay. They said you had contact with someone that was positive.
Yes.
All right.
And
so like okay.
And
you wanted
the person
something.
that they said I had contact with, that person, for me, I believe the person is not COVID. It's just malaria, because the person is fine.
Okay.
I believe it's malaria.
Is the person at the isolation center?
They've discharged him. He came back.
He's back now.
At home.
Okay. So, Mr. David, like I explained to you earlier, there are some people that don't show symptoms at all.
Okay.
So it means you fall under that kind of category. You are asymptomatic. That is why you are not showing any symptoms. So now I want to advise you
Address me now.
Hello.
Doctor, are you there?
I think we have lost. I've covered everything possible. I don't know.
Yeah. Yes. Now, I think we have lost David, no doubt.
I'm here. David is there.
Okay. Okay. Now, you did you provide the information about waiting to be picked? I think that's what you are going to advise, Abi.
Yeah, I think we lost here today.
Okay. Going forward, you could see that despite the difficulty the client was posing, she knew the information to deliver, and she was about going to deliver those information. Okay? And that is why we said you must understand what you're expected to do at any point in time and be able to know how to break resistance. All those difficult things David was trying to create is what we call what? Resistance. And by the time you understand the art of
Resistance.
breaking bad news, you will be able to know how to maneuver them swiftly. And that was what Yetunde was doing. Okay? And I can assure you, it didn't just happen like that. It's something that is acquired with experience. Okay? So I thank you both of you for that beautiful presentation. At least he has given us an insight into some of the challenges we'll be getting by the time we start making calls. Thank you very much. So, Dr. Shokunbi, over to you. Uh-oh, we've lost Dr. Shokunbi too.
Okay, let me just say something since except she comes back on. Dr. Shokunbi, let's know when you're back. I would just want to add, because I see that someone asked a question about frequently asked questions.
Okay.
So we are trying to actually collate that so that we will be able to put that up intermittently as a guide, because we, yes, really have been experiencing questions from different angles, and we're actively putting that together now. I think Dr. Fashanu and myself started working on it yesterday. So we should have that for you within the week. The other thing is, you may not necessarily have all the answers. Please, it's not necessarily a bad place to be. It's just that you need to just check in again very quickly. Those of you on the disclosure activity, I think your immediate person you should ask questions will be Dr. Fashanu and Mr. Olumide Okeowo. They're on the chat and they do respond. I also do that from time to time, and we'll take it from there. There would also be guidances for these calls. So some of the things that Dr. Umeh has spoken about today, we have a brief guidance that you can just have, and you can make reference to when you're about to start making your calls, the things you need to do in that call. The guidance, will post it intermittently on the general volunteer group, so you can go back there and pick it. There's this inpatient booklet, patient booklet that I posted yesterday. Please take time to take a look. That also gives you a bit more information. So lots of this information, you will pick it over time. Well, I just want to reassure you that once you're mindful of all these little things that we're adding, I think the group has been carefully selected, and we believe that you should be able to make the best of it. There's one last question. Dr. Shokunbi, are you back? Dr. Shokunbi? Okay. So there's one last.
I just came back.
Okay. All right. Welcome back. I was just giving a little bit feedback. Okay.
Okay.
So there's one question that someone just dropped, and before I hand it back to Dr. Shokunbi to round up, I want to know, sir, if discharge, follow-up, community service, and home care are the same. Dr. Umeh, can you speak to that, please? If discharge, follow-up, community service, and home care, whether they are the same?
No, they are not the same. Okay, community service is like there are people in the community who have concerns, who have issues, who are already distressed because of the COVID circumstances. Okay, and now there are some members of the team who reach out to those ones. Okay, and those ones, their job is to deal with their immediate problem, and if it requires escalation, if there are major mental health issues, they can escalate. Okay, that's the community. Now, the post-discharge, at when they are discharged, they go back to the community, and some of them encountered different problems, ranging from discrimination to stigmatization. Okay, and when we reach out to them, we'll be able to tease out all these issues and be able to escalate. A case in point was one that was in the press then that virtually everybody read. Okay, she was discharged and she was making noise that she was discharged, she was let off her job because she was COVID-19 positive. So they said that we escalated that to the Attorney General or thereabout before the issues went basic. But normally, if people who are discharged are having issues in their with the organization and others, we need to see how we come in to deal with that. That is still part of us. And part of what we're trying to do to help deal with that is probably providing them with discharge certificates. That discharge certificate, some organization will ask them, maybe you are treated. We want to be sure that you are clean, okay, and they can reaccept you back. So they ask for discharge certificate, which Dr. Oshede and Ms. Saikomo have processed in the past, and those ones are cool with that. Okay, so I think those are the levels. But you know, it's like from stage to stage, but they are not just the same. There are peculiarities among all those categories.
Thank you, Dr. Umeh. Dr. Shokunbi, sorry, over to you.
All right, thank you very much, Dr. Umeh, once again for that beautiful and very productive section. I want to believe everybody enjoyed this section. So if you truly enjoy it, I want you again to unmute your line and give Dr. Umeh a shout of thank you.
Thank you, sir.
Thank you, sir.
Very much.
Thank you very much, Dr. Umeh. We are very, very
It was really thank you, sir. Thank you very much.
Thank you for a very productive session.
Thank you, sir. Thank you.